All right, so I will go ahead and get started. So I want to welcome everybody to the final seminar of our academic year with the Lee Kum-Shung Center for Health and Happiness. We are really happy to welcome Dr. Carol Graham. She is the Leo Pasvolsky Senior Fellow at the Brookings Institution in Washington, D.C., a College Park professor at the University of Maryland, and a senior scientist at Gallup. Her areas of expertise include the study of poverty, inequality, subjective well-being, the economics of happiness, and development economics. She's editor at lots of journals. She serves on editorial boards of tons of other journals, author of numerous books, and has provided a lot of really excellent policy advice and thoughtful input on how we should be thinking about measuring well-being and when to use it and how to measure it. So we are really happy to have her here today. Her presentation is going to focus on the impact of COVID-19 on the excess deaths of despair in the US. And she's going to discuss her findings in the context of how levels of resilience and optimism vary among groups characterized by different racial identities and socioeconomic status. What I was going to say about the organization of the seminar is we'll ask you to put any questions you have into chat. And when Carol's finished her talk, I will moderate and sort of share the questions with her, and we'll hopefully have some time for Q&A and some discussion. So I think with that, I will hand it off to you, Carol. Thanks.
Well, Laura, thank you very much for having me. And I'm going to be unused to all the silence because I'm used to rude Brookings economists that interrupt you when your first slide is up. So I'll have to get used to that. But anyway, so let me start by sharing my screen. Now, I can't see any of you now. So that is there something I can do?
Not really easily. We could kind of walk you through how to do it, but I don't think your screen is, let's see, is your screen being?
Maybe I can do, no, I think I can do gallery view. Okay. Oh, it is gallery view.
Jamie, are you able to see Carol's screen?
No, we don't see it yet.
Okay, well then I think I'll just talk to I mean, I can get it up. Can you see it now?
No.
No. Hold on. Okay, good. There we go. Success. Sorry about that. I might have just put it up and not hit share screen because I did earlier, but hopefully this works. Okay, how's that? Everybody can see it? Okay. All right, well, trying again. So again, thanks for having me. And this is a great group to present to, obviously. And I really welcome any feedback because we're going to be doing more on this as we go. So basically, I've been, over the past 10 years, probably working much more on well-being in the United States than my original work, which has been on well-being in poor countries around the world. I'm from Peru originally, and a lot of my work pre-well-being days had to do with poverty, inequality, and public health in very poor places. But coming back to the US over time, particularly in the past 10 years or so, I kept wondering sort of what was so depressing essentially about poverty here, even though, materially poor people in poor places are more deprived, but in the US there's a certain hopelessness to it, or so I thought. And then I explored it in the data and really was amazed by the trends. And sometimes I've called it the high cost of being poor in a rich land. And there's more to it, but I think there are certain things about poverty, being poor in a very rich context. One, because it requires more material, goods to just survive, but also that, the relative differences are greater. And then, of course, the US is pretty unique for not having a national health service. So it's very hard. A lot of people just can't get basic health care very easily. So there are a lot of things about the US that explain it, but that there are also a lot of big differences across races, some of which are surprising. And most recently, I've been working on our high levels of inequality and well-being, not just inequality in income, but also our inequality of well-being, and tracking those with deaths of despair in the United States. And one of the things that's remarkable is the gaps between the well-being of the rich and poor are much greater in the United States than in Latin America, where you see much more equality in levels of hope, in levels of reported stress, and a whole bunch of markers, versus the gaps in the US are about 20 times greater, which is surprising given the context. And then the other thing we've been looking at in more detail is the role of hope in driving investments in the future, in driving future health and prosperity. And we find that hope really is a channel to longevity. I think, Laura, you've also been working on some stuff like this, and our findings certainly relate to each other. But the other side of the story is lack of hope or despair, and what that leads to. And I'm going to talk a fair amount about despair today, and how that is really a big factor in what's going on in the US today. And again, big differences across races. So one of the things that, among others, that I've found is that the increases or rise in despair among low income or blue collar whites, and white men in particular, started in 1979 with the first wave of the decline in manufacturing and the decline of their narrative for living. And the deaths of despair started in about the year 2000. So if we'd been tracking well-being metrics like so many other countries do, and I worked very closely with the Brits from day one when they started to put well-being metrics into their statistics, we would have picked up on the fact that there was something going on in a big cohort of people, because well-being doesn't change very much. It's pretty stable over time across populations, unless you have a really big hit like COVID. And yet, so when you have a big change, you sort of wake up and say, you want to explain that, whether it's a positive change or a negative change. So if we'd been tracking well-being at the time, we might have picked up on something wrong in a particular cohort and high levels of despair well before it turns into a crisis of mortality, which is what we have. And then on top of that, now we have an additional challenge posed by COVID, which I'm sure all of you have been reading or possibly working on, the extent to which mental health and other kinds of well-being have been negatively hit by COVID, which isn't a surprise. But what we find, and also in the UK, the markers are very similar. Already disadvantaged people, disadvantaged in terms, not just in economic terms, but in terms of low levels of well-being, high levels of loneliness, high levels of reported depression, were hit hardest by COVID in terms of the well-being hit. So I thought I'd say a couple words about the measurement of this, because I don't know, hopefully I'm not boring everybody, but I can get through this quickly. Just want to make sure that people are clear on how we measure reported well-being or happiness or life satisfaction or stress or a whole host of things that we measure. So we basically have large N data, and we have econometric equations where W in this equation is the well-being of individual I at time t. So that W could be reported life satisfaction. It could be predicted life satisfaction in 5 years, which is essentially a proxy for optimism. It could be, were you stressed yesterday? Were you worried yesterday? And any one of those things that we measure. And then the beta XIT is a vector of socioeconomic and demographic constraints, which we can control for. And the error, unlike economists' standard treatment of the error term, which is to toss it away as bias or noise in the equation, in well-being equations, the error term actually contains a lot of information. It contains what we can explain by observable factors. And we can explain individual well-being, about 30% of it, by observable explainable factors, and the rest is innate to people's character traits. Now, 30% is a very rough estimate, but it gives you an idea that there's a lot of variance across people that we can't explain. And that's captured in the error term. And in the past, in a much earlier paper, we actually calculated the residual or unexplained happiness for each individual's, for each individual respondent, and we were able to use that as an independent variable in a second stage regression, which was for people's outcomes 5 years later, and we found that this unexplained well-being actually had really significant effects on people's future income, health, and other behaviors. So that was a hint very early on that their well-being causes certain things. It's not just what determines life satisfaction or well-being, but that higher levels of well-being actually result in better outcomes. And the opposite of that is low levels of well-being result in worse outcomes. So there are remarkably consistent patterns in the determinants of life satisfaction around the world. So yes, money matters. More and more money doesn't matter necessarily, but once, people with more means have the ability to make choices about the kinds of lives they want to live. And of course, you're going to be happier with your life as a whole, or your life satisfaction as a whole, if you've been able to have some say over what you're doing and how you're living your life, versus people who are destitute. It's often determined by factors outside their control. Income matters less to what we call hedonic or experienced well-being. That's kind of daily moods, or stress yesterday, or contentment yesterday. Health matters a great deal, often more than income, depending on the sample and what else is in the equation. Employment matters a lot. One of the things that we find, people are incredibly adaptable, and they can adapt to a lot of things, but long-term unemployment is something that people never really adapt back to their pre-existing well-being levels. And that's very relevant in today's context when you think about COVID and what's going on in the labor market, and what prospects for decent employment will be, in a world where low-skilled jobs were already disappearing. And now with COVID, we've sort of done a great job of demonstrating how low-skilled jobs can be replicated in lots of different ways, whether it's Amazon or who knows, and technology, and how much technology is taken over. So that long-term unemployment question is, I think, one issue in despair in the United States and a lot of other developed countries. And I mean, over time, that's gonna just spread around the world. We're gonna really have to think about the future of labor markets. And then marriage always comes in as positive in these well-being equations. I hate to burst anybody's bubble, but that's really an artifact of construction in the data, because what you're doing, if you're looking at one point in time, you're looking at people who have married each other and comparing their levels of well-being to those who never married, and happier people are much more likely to marry each other. So the very few over time studies we have of marriage show that the actual effects of marriage alone, not the pre-existing happiness levels, lasts about 18 months. And then these already previously happier people go back to their sort of relatively stable happiness levels, and they're still more married than the single people, they're still happier than the single people, but the marriage effect is worn off. And a wonderful colleague friend of mine in France has written a paper called "You Can't Be Happier Than Your Wife." It's in the Journal of Economic Behavior and Organization. And it basically shows that the probability of divorce is highest when you have asymmetries in marriage levels. So it's better to have two happy people married to each other, or two unhappy people married to each other, but you don't want a happy person and an unhappy person married to each other, because they drive each other crazy. I actually had that experience, and you can guess that I was the happier one in the situation. Anyway, so once we control for these things we know are consistent around the world, we can then explore the happiness effects of things that vary or change more, such as inflation or unemployment rates, inequality, environmental quality, commuting, smoking, exercising, and much more. So the most important thing to remember from this slide is that we're not asking people if these things that we're measuring make them happy or unhappy, right? We're essentially, we ask them the well-being questions up front, and then we control for all these other things, and then we can see what varies. So one last thing on method, which also leads to the substance, is one of the most remarkable findings in, at least by economists. There's some debate over economists and psychologists about this, but the large N data really shows this, is that there's a U-shaped relationship between happiness and age that holds in most countries around the world, and except for very poor or violent ones where it's terrible to age. And it turns in about the middle age years. So there are a lot of explanations for this. First of all, there's the standard middle-age stress where people are time constrained, they're often financially constrained, they may be taking care of older parents and young children or teenage children. There is a psychiatrist explanation, which is that people get emotionally wiser as they age, so they have less emotional swings, and that explains part of this. There's also selection bias because happier people live longer. So some of what you're seeing as you go up the age curve is that the people who survived were happier to begin with, and the less happy people have died off. Sorry to be morbid, but anyway, there's variance. Happier individuals turn earlier and live longer, so they have more happy life years, which is sort of unjust, but that's how it is. And people in countries where it's pretty difficult to age turn much later. So in Russia, the low point is about age 60, which is also life expectancy for males. So you can figure out what's going on with the females as they get older and the men have died off. I don't know, it's just saying. But anyway, this is that when you think about deaths of despair, which are these deaths by suicide, overdose, alcohol poisoning, and other preventable causes, they're the biggest in the middle age years. Now it's particularly with COVID and some other data I'll show you, we've seen a bit of a spread to younger people and slightly older people. So this middle age band is bigger. But initially when we first started working on these, they were roughly between, say, 40 and 55 years of age, which is exactly the low point on this curve. So I mentioned that there are big racial differences in well-being and optimism in the United States. And if you look at this is comparing low-income cohorts. So the left-out group are poor whites, roughly the US poverty line in the Gallup data. And you'll see that African Americans are almost 3 times as likely to be higher up on an 11-point optimism scale than are whites. And when I first found this, I was quite surprised. It was before we even knew about deaths of despair. It was 2015 when we had police violence in St. Louis and Baltimore, big riots, a sort of much earlier wave of similar trends that we've had this year. And I expected that Hispanics would be the most optimistic group. As I said, I'm from Latin America, and Latin Americans are very optimistic, and that there would be some distress among the African American community, and whites would sort of be boring in the middle. But this is the opposite of what I expected. And it turns out now that I've been studying it, there are historical studies. I'll show you some data during COVID that's remarkable. But this is a very persistent optimism finding. And there are lots of explanations for it, which we certainly could get into in the questions. So here is, now this is an early slide depicting deaths of despair. As I mentioned, there's been some spread and change, particularly since about 2018 with the entrance of fentanyl, a very powerful opioid that has spread more to urban areas and to minorities. But prior to that, if you look at this is several wealthy countries, 6 countries, and this is basically the all-cause mortality rate for 45 to 54-year-olds. And the USW at the top is US non-Hispanic whites. It's the only country of the 6 where mortality is going up rather than down. Obviously, this is pre-COVID. The thick blue line that says USH is US Hispanics. And as you can see, they've been tracking downwards, maybe starting from slightly higher mortality levels, but they've been tracking downwards along with the other rich countries. If this chart had data for African Americans, you'd find a similar trend for both African Americans and Hispanics. And it's essentially middle-aged, blue-collar, and less than college-educated whites that are driving these trends. So these are a lot of deaths. Prior to COVID, in the past 3 years prior to COVID, we had about 70,000 deaths of despair per year annually. And you have to have a lot of deaths to drive up the overall national mortality rate. So it's a problem for a country. It's certainly a health problem, but as I'll show you, it's a problem in terms of economic productivity. It's a problem of in our civic discourse, the levels of despair we have, and more. So I'll show you some place-based findings where some trends coincide in a couple of slides. So the first thing we did was try and track, because of the historical findings and because of the similarities in the patterns of deaths and the despair among low-income whites, we tried to track or see the extent to which trends in deaths of despair tracked along with and possibly could be predicted by trends in well-being. We focused, the markers that we found to be most robust were despair or lack of hope on the one hand, and worry and stress on the other. And what we found is that at both county level and MSA level, the CDC composite death rates for 35 to 64-year-olds, as I mentioned, there's a bigger spread of years now for deaths of despair, was negatively correlated with optimism and positively correlated with stress. Now that's at the individual level, but I think there's likely two-way causality, because if you live in a place where a lot of people are dying of overdose and suicide, it's likely that the probability that you will fall in that category is higher. So we're not claiming sort of clear one-way causality, but that there is a strong association. Then another paper with Kelsey O'Connor and using the US PSID panel study of income dynamics over time, we find that optimists live longer. And as I mentioned, less than college-educated white males dropped in optimism in the late 70s, long before deaths of despair. So there are lots of ways in which well-being markers can be warning indicators. In this case, certainly the falls in well-being clearly predated the increase in deaths. And there's a strong, robust association between despair and these deaths. That's why they're called deaths of despair, obviously. We also looked at place and health behaviors such as smoking and exercising, and we found indeed that places that have higher levels of well-being and lower deaths of despair have healthier behaviors across the board. Not surprisingly, they're more likely to be diverse and urban, right, versus rural or suburban and in the heartland. And that's also correlated with more vibrant economies. It's correlated with more diversity. And some of that is an artifact of construction. If you have a higher share of Blacks and Hispanics and they're more optimistic, that's going to affect your aggregate measures, place-based measures of optimism and lower levels of stress. And then what we find is not only are these despair deaths disproportionately concentrated in blue-collar white communities that were formerly dominated by manufacturing or mining firms, and are now declining communities, so also is the related phenomenon of prime age males out of the labor force, and that cohort in particular has very high levels of opioid addiction. Again, for reasons I can explain in more detail in the questions. I'm cognizant that I should move on a little bit here. So then the latest research we've been doing is trying to track where COVID and deaths of despair coincide. When we first started doing this, COVID was hitting minorities in cities and deaths of despair were in the heartland, roughly speaking. That's changed very much now, and there are places where these two things coincide. And if you think about rural places with high levels of despair already, enter COVID, there is not much access to good health care. Often a hospital is 2 hours away. And so we're starting to see, big associations between both despair and the COVID death rate, as well as the pre-existing deaths of despair. We've been using, because CDC data lags for several, often a year, often 2 years, we've had to switch our mortality data. And initially we worked with the CDC data and the Hopkins COVID tracker, but now we're adding in new first responder data from the NEMSIS. It's a government agency that collects this data for 49 states now. And so we can track in real time, we can compare averages for 2018 and 2019 in overdoses, suicides, mental and behavioral health reports, gun violence, all kinds of stuff with the 2020 data, which EMS has, but the CDC does not have yet. And then also some new well-being data from a new Gallup panel, and then a joint survey I've done with some scholars at WashU that are doing, that are providing more well-being data in real time during the COVID during the COVID pandemic, and then also the Census Pulse data. So we created this new interactive indicator, which we are now going to be upgrading thanks to generous support from the Robert Wood Johnson Foundation, and making the existing interactive indicator, we're both updating it. So we'll be putting in all the data running through 2020, where you can compare, you can see places, county levels of well-being or ill-being, and also the death rates for both of the pandemics, and also the poverty rate and unemployment rate and other things. There's a link to it there. I'm happy to send that after in an email if anybody's interested. But we're also going to be, as we upgrade it, we're going to be looking at the kinds of policies, and in particular well-being policies and other policies that these places also have, so that we can kind of get a sense of which are the places that do better amidst these challenges and which are the places that don't. And the latest, sort of our latest paper has been on prime age males out of the labor force. So before COVID, when we were boasting booming stock markets and record low levels of unemployment, 20% of prime age males had dropped out of the labor force. That's a large number. It's just the way the unemployment rate is measured. If you haven't looked for a job in 6 months, you drop out of the pool. So the ratio, these people just fall out of the ratio. So we were saying we have 4% unemployment, but we had 20% of prime age workers out of the labor force prior to the COVID shock. What we find when we look at the health and well-being and other things about prime age males out of the labor force, and in particular the white prime age males out of the labor force who fare much worse on all these indicators than minorities, we find they have worse well-being metrics than any other labor market cohort, even the unemployed and the retired, very high levels of despair, poor objective health, high levels of reported pain. There is no objective reason why white men should report more pain than African-American or Hispanic men. We're talking about prime age males out of the labor force now. So there's something more to it, whether it's psychological pain, which we're obviously seeing in deaths of despair, whether it's linked to being prescribed opioids. There are lots of reasons for it, but it's unusual. And the US, meanwhile, has higher levels of reported pain than 30 other countries, many of which are much less wealthy than we are. So there is something going on there. And again, my suspicion is that there's psychological pain is driving some of this. They also are worse in reported disease diagnosis, opioids, and whatever. Here's the link, though, to our economic productivity and geographic mobility. White prime age males out of the labor force are much more likely to live in counties with a high incidence of deaths of despair. They're also more likely to still be living in their parents' homes or census tracts than any other labor market group. So if you think about their despair and opioid use and not high levels of skills, it's very unlikely they're ever going to move to new jobs, even if there are, economic opportunities in their proximity. And so we calculated sort of the extent of this is one reason for our falling levels of geographic mobility. People are much less likely to move to jobs today than they were 20 years ago. Okay, last thing, and then I'll show you quickly the COVID data. So this is this is a mortality map. As you can see, the darker places are where the highest levels of deaths of despair. So place matters. Communities that are declining tend to have vicious circles of despair and these kinds of deaths and other things. Excuse me, somebody who I don't want is calling me. So if you superimposed, there's some new work on advanced cognitive skills. So if you imposed the cognitive skills map, where there are cognitive skill deserts, they are very similar to these places. If you put opioid addiction, very similar to these, these rough patterns. If you put reported pain, again, reliance on disability, again, these patterns would show up as a place-based patterns. If you put Trump voting, that would also show up. So there's a lot going on. These high levels of social despair are leading to a lot of outcomes that I think are, pretty corrosive right now. And there's, you can talk about cause and effect, but I don't have time right now. I'm going to try and get to the end. So place matters. So now what happens with COVID? Enter COVID. this is opioid overdoses. The yellow is 2019 to 2020, and 2018 to 2019, you see the averages for the previous 2 years. There's an almost doubling of overdoses based on this first responder data in the COVID year. And that's, that means on top of the 70,000 annual deaths, we're roughly up another maybe 40 to 50,000 deaths. These estimates are rough because overdose data, you don't know if people die of an overdose, was it a suicide, was it intentional, was it a mistake? There's also this puzzle that suicide rates went up initially in 2020 and then fell. Now, again, we don't really know. We don't have good data. It could be that people who were older people in poor mental states are more likely to commit suicide, or at least older, the end of the middle-aged years. They might have died of COVID, right? We really just are not sure. First they spiked and then they went down. And I don't think we'll know till we really have the final mortality data from CDC what happened to suicide. But overdose rates are way up. Mental and behavioral health calls are also up somewhat. They drop quite a bit sort of towards the end of the 2020 year. One reason may just be that there are less people on the street. People are some of these calls, people observe somebody in their street acting weird, and they call the first responders. So some of that drop may be to social distancing and quarantine. But anyway, we are just seeing a general increase in poor mental health. Now, here's what's remarkable. So this is optimism and stress during COVID. This is from our WashU survey. And here we find that, once again, the most optimistic group throughout the pandemic, this is 4 waves of the pandemic. The left-hand side is optimism based on the 5 years predicted life satisfaction question. These are low-income groups. And you see there's a May wave, an August wave, November wave, and February 2021 wave of the survey. And low-income Blacks are the most optimistic group throughout a pandemic that hit them the worst of all groups. Hispanics also got hit badly, and you can see Hispanics optimism varies much more, but this steady optimism gap is, in my view, remarkable. If you think it's a bad question, look at the right-hand side. That's stress. Again, low-income Blacks, much less likely to report stress than the other groups. Objectively, that just can't be right. I mean, in the sense of that they're clearly experiencing the same kind of stress and more stress than these other groups during COVID, and yet they're more resilient. So there's a lot to this, and obviously one of the things I want to know, and is one reason for better understanding it, in addition to it being remarkable, is that can we learn from this optimism and resilience for communities, different of different races who are clearly in distress, and we're trying to turn around in terms of getting them out of despair. So that's a big open question, and I don't know what the answer is. Just to show you anxiety, this is Census Pulse data during COVID, and you can see it peaks with the waves of higher death rates, essentially. Look at, you'll see one peak for African Americans around the time of the election, more than anything, but it's generally reported anxiety is lower. Remarkably, the European studies that we have and the Gallup data that we have show that life satisfaction fell right before the onset of lockdowns, and the initial lockdowns, say in March and April, you saw a drop in life satisfaction. But after that, in both Europe and the US, people recovered their basic life satisfaction. One, I think because they realized, I think there was a sense of relief that the government was doing something about the pandemic, even though lockdowns may not be popular. But two, that people could adapt, right? They could adapt to this new reality. They might not like it, but people are very, are remarkably adaptable. As you can see, anxiety is something that moves much more with the COVID pandemic. So this is really research in progress. So I can't say I have any great conclusions, except that we are really trying to do a lot of work understanding hope. We have some new hope survey findings from poor adolescents in St. Louis County, Missouri, where we get the same gaps in optimism and hope between low-income African-American kids and the low-income white kids. We have an earlier survey on trying to understand hope in Peru, which has had 2 rounds, and there we find that our high aspiration, hopeful adolescents, these are kids about 18 or 19. We re-interviewed them at age 20, 21, and most of them, they had high aspirations for college or graduate school. Try that in low-income white Missouri, and you're not going to find it. But in Peru, we found that the high aspirations kids were actually achieving their aspirations. They were more optimistic. They had lower discount rates, or lower levels of impatience, might be a better term. They had higher levels of self-esteem, and they typically had a mentor and a supportive community, whether that community was family or their neighborhood. Peruvians believe very strongly in education, and that filters through. When we look at the initial surveys in Missouri, we're finding that the white kids' parents do not aspire for them to go to college. They only aspire for them to go to high school and finish it, and that's it. And that seems to constrain the kids' aspirations as well. And so my objective in this research is to say, do you want the children of prime age workers out of the labor force to have the same fate, which includes high levels of despair and no life narrative? We've got to at least start thinking about how the next generation can make it, how they need to train. They don't all have to go to college, but they need cognitive skill training. They need something, and they also need hope, or they're not gonna go anywhere. So I could talk more about all the bad things COVID has done and the increase in gun violence as well, and that I've showed you the charts on increase in deaths. We basically have to take this issue on, and if there's anything good in the story, I've found an incredible amount of receptivity to an idea I floated to sort of people, both academics, but also policymakers in the agencies, about we need to coordinate our efforts for community renovation, economic recovery, and fighting despair, because we're not going to recover economically with populations with this much despair. And then the other thing is that some of the agencies, the feds, the Bureau of Labor Statistics, the census, which we never thought would happen in the US, are starting to measure well-being because they've realized, because of the crisis of ill-being, that they have to focus on it. They're not doing it right, and they're not, they seem to be unaware of all the work that's done in terms of measurement guidelines, but we can, that's something we can, since they're responding to us, we can kind of hopefully correct course on that. But we've sort of, I think, at least there's a much more going on in this space, and including at the local and community levels, with realizing that the sort of vulnerability and mental health of our society has become essentially a social crisis, and COVID both exacerbated, but I think also woke people up to it. So sorry, I think I've gone on a bit too long, but I guess over to you, Laura.
No, that's terrific, Carol. Thank you so much for a really thought-provoking and interesting talk. So I think we're going to open it up to questions. People can put them in the chat, and I can moderate. I did have a question already, which actually not from me, from someone in our Zoom room, which I'll start with, and then we can go from there. So one of our folks said she would be interested to hear more about racial disparities and optimism that you were finding, and what are some of the possible explanations for why you think we see those?
So I think, as I said, when I first got these findings, given what was going on, in terms of disparity and violence and everything else, and now through COVID, just seeing how persistent they are, I've looked into the history of it a bit, and they're not, these are not new. We just didn't know really much about it, but there's been a historical resilience. And again, it comes out in so many ways now. For example, most people may become happier as they get older, but they get less optimistic, because particularly with that life satisfaction in 5 years question, because, by the time you're 75, you're kind of like, well, I don't think my health is going to be that good in 5 years. I may not be here in 5 years. So you find, even though it's like, okay, I'm satisfied with my life, you're not predicting big, good changes. Older African Americans are the only racial group that retain their optimism much into older age, which is again another sign that there's something going on. So some of it's historical resilience in the sense of having faced adversity over a long period of time. People build coping skills, and we see a lot of this in, among poor populations around the world as well. There may be a selection bias because to survive, if you think about it, to survive navigating the U.S. system as a low-income person, it takes a lot. And I think this optimism channel is more important for people with less means because it helps you get through. There's also, if you just look at a traditional objective economic and health data, what you see is despite, there's a lot of bad stuff out there, but you see despite all of that, both Hispanics and African Americans have been narrowing the gaps in life expectancy, in education. Marriage rates now are no longer, it used to be the marriage rates in the US were very different across races, with whites the most likely to be married, but now low-income whites are less likely to be married than low-income minorities, or at least about the same. So we see that marriage rates are now an income story, not a racial story. And then I think there's also a turn, so that they've been making gradual progress. There's a sort of, I think there's this other channel, which really comes from knowing that the system isn't going to do it for you, so you have to do it. Versus for a long time, the narrative for blue collar whites was you finished high school and you got a job, just it was primarily a male narrative. You got a job like your father had in the manufacturing firm or the mine, and you worked hard. That there was not, these were not glamorous jobs, but you had a respect and a stable lower middle class existence. For whites, for minorities, there was the narrative was quite different. It's like the only way you're going to get out of this is if you get educated. So interestingly enough, if you talk to, for example, the heads of historically Black colleges and universities, they will affirm that low-income minorities are much more likely to believe in the value of higher education. And particularly in some of these same places that I showed you that keep tracking the same way, there's a lot of skepticism of higher education, and ideology's gotten involved. And now, higher education is a plot of coastal elites. And so you don't believe in science anymore. And so it's a really complicated set of issues, but it's just not, some of it's historical, some of it is perhaps innate character traits, in the same way that you see cultural differences in optimism and resilience. Some of it is just the decline of the working class white narrative, and there isn't anything there to replace it. And make America great again is not going to do it, right? There needs to be some sort of path to a meaningful existence.
Yeah, that's great. We actually had a really interesting speaker recently, Michelle Lamont, who spoke a lot about the need for some new narratives to try to fuel some greater well-being, which I'm happy to share some of her work if you haven't seen it.
I'd love to see it.
Ton of questions coming in, so I think I'm going to try to move through them and get through as many as we can in our time allotted. So the question, the graphs on optimism and stress for whites, African Americans, and Hispanics are based on the Cantrell ladder representing the best and worst possible life for you. Is it possible that by construct this measure then incorporates an acceptance of the existing inequality and opportunities based on race? So for example, I'm African American, so I'm aware of the inequalities existing for me, and my response to the best possible life is subject to that. So measures are not really appropriate for cross-racial comparisons.
I mean, if that was the only finding we had and the only data we had, you could make a bit more of that, but they're two different things. Even within the same Gallup data, these are not Pollyanna findings. They're not sort of defeatist findings. These same respondents who are more African-American respondents are much more likely to want to give back to their community. They're much more likely to believe that to report their financial situation is not good, right? So they're not sort of being Pollyannas, that their city is not safe, but they want to do something about it. And then we find it in, the PSID is a completely different question. It's a question about life working out. So we find it with other markers of optimism, my adolescent surveys, right? These are a whole host of questions. We use hope. We have an optimism question. We use the Cantrell ladder question. The findings are all in the same direction. So it may be, and I guess across rich cohorts, you could think, there's now a sort of a wider spread societal belief that people's kids won't do even as well as they will, as well as they have. And apparently African-American parents score much higher on thinking their kids will do better. But I think there, that might be a glass ceiling effect, but that's not going to be, there's no glass ceiling for where low income whites are. They're in relative decline. And I think it's their perception, correct perception that they're in relative decline drives some of the difference. So you have this historical optimism and resilience among African Americans who are sort of gradually continuing to progress against all odds. But you also have a relative decline in all of these things among low income whites. So there is kind of if to the extent the finding is some sort of artifact of construction, and I think there's more to it, it's as much driven by the decline in optimism and the increase in despair among whites as it is among trends among Blacks.
Okay, thank you. So Beth, you had a hand up. Beth Stelson, I don't know if you wanted to come in with a question. I saw.
I see a question about religiosity, which I can really answer quickly in the chat.
I'm sorry, I was having trouble unmuting myself because of the automatic settings.
Okay.
And I was just about putting the question in the chat. So one of the things I'm curious, and this builds off of what you were saying, is that I noticed on the image with the anxiety among African Americans, there was also a spike around Breonna Taylor's and George Floyd's death. And if we're thinking about the corresponding of kind of these two, you have the pandemic, but you have also this overlaying of racial injustice, greater recognizing, which would increase anxiety, but I could also imagine increases hope, which is also, I think, what you were just speaking to. And so I'm wondering how much of these observed effects could actually be explained away maybe by this movement that we're seeing coinciding.
So yeah, I explained away is I think probably too big a term, but what we found was while you see spikes in anxiety, you didn't see drops in hope, right? So hope and anxiety can coexist, and obviously the movement at some, I think beyond just African Americans, for many of us, created a sense of hope that this could change, but it did also create a sense of anxiety about how this could happen, what would happen, and particularly given the administration that we had in place at the time, even more so, that how much conflict would it all come with. So it's a great observation, and we also looked for kind of George Floyd effects as we were doing this, because it was such a movement. So anyway, thank you. Yeah, that's a great question. And on the religiosity question, that somebody in the chat asked if this was driven by religiosity, and African Americans are indeed the racial group that is most likely to say religion is important in their lives in our data. We controlled for religion because not that we don't care about it, but I wanted to make sure that was not what was driving this finding. And then the other difference is that the kind of communities, I call them communities of empathy, that which are sort of those extended social ties that minorities, Latins and their extended families, African Americans and their churches, and also extended families. These communities were built out of a need to keep each other going, to support each other in the absence of better, public systems, and also in the context of adversity. And these communities are about, others. They're not just about, the individual work ethic. And even the churches that a lot of, not all, but a dominant religion among blue collar whites in the heartland of the country are the evangelists. And it's a church that focuses more on people's individual relationship with God than on community. So I'm not an expert in religion, but I have looked at these patterns a little bit. And so the short answer is our findings are not driven by religiosity that we can observe, but there are unobservable things about having these communities of support that matter, and they show up in the adolescent surveys as well, the very optimistic Latin American kids, and then the differences across races in the US. That all, having some sort of community, whether extended family or just, church or whatever it is, seems to matter to kids having aspirations as well.
Okay, so moving through, we have so many questions. So here's one from Eric Coles. Are there any expectations that the diseases of despair will move to other demographic groups beyond low-income whites? I'm wondering specifically if diseases of despair could mark a new epidemiologic transition. That's a cheerful question.
Yeah, well, and the answer is no more cheerful because they have. As I said, fentanyl has been a game changer. Prescription opioids were Blacks were much less likely to be prescribed opioids, which was clear discrimination. But in an ironic way, it was preservative at that point in time. They were primarily prescribed to white manufacturing workers, white miners, historically over time. And so, but once regulation caught up with the pill mills and the opioid crisis and everything else, people turned to more illicit drugs. And that's sort of filtered over time. And now you see, for a while it was more standard kinds of heroin, meth, whatever, but one of fentanyl, which is incredibly powerful and because it's very illegal, it's obviously very difficult to predict what's in the batch you get. So we're seeing a lot more overdoses with fentanyl. Unlike opioids, which were more concentrated among whites, fentanyl is also quite prevalent among older urban Blacks, many of them former crack addicts. So it's kind of more concentrated to a specific group. The other very worrisome trend we're finding is high levels of depression among wealthy African-American teens and some spikes in suicide there. So there is a spread. I don't think we know how big it will be. We don't exactly have a very good controlled time trend because COVID sort of blew everything up. And I guess we're going to have to regroup and see the extent to which these trends were driven by COVID and might stabilize again, or whether, as you say, we're having a kind of epidemiological change. I hope the latter isn't true, but I think it's too early to know.
Yeah, there's sort of a related question that I'll just bring up now out of order because so we've got, according to data from The Economist, suicides became more rare during the pandemic, April to July 2020, including in the US. Do you think this is due to lack of proper reporting because of the overlap with overdose deaths? And do you have any other thoughts on that?
This was suicide, right?
Mm-hmm.
Sorry, I just couldn't hear that part of it because they're replacing the air conditioners in the attic, and occasionally I'd miss a beat there. Well, that's my view. I mean, I was quoted in the Washington Post fact checker saying the same thing, that we had a spike in early 2020 in suicide, and then it went down, and so suicides are, as measured by CDC data on suicides do not seem to be greater in 2020 compared to 2019, but overdoses have doubled. So, who knows? Because it's maybe it's harder to commit suicide when everybody's locked down. I don't know. Maybe overdose. As I said, in our earlier conversation, it's possible that some older mentally distressed people, or middle-aged distressed people who would have committed suicide under normal times died of COVID. We don't know too much about the confluence of COVID deaths and suicide deaths for obvious reasons, and we don't know how much of the opioid overdose increase was intentional or not, and intentional would be very likely to be coded as suicide in the longer term. So it's a challenging reporting puzzle. I hope we get a little more clarity when the CDC 2020 data is out at the end of this year. There's another thing that I just thought of that may also be something, which is that we know that suicides are actually higher in happier places. Some of this is some of it is a reporting error, a reporting thing, because suicides are much less likely to be reported in Latin American countries and, you know, some other places for cultural reasons. But there is something about, you know, for example, we know that kind of higher levels of happiness and other dimensions of well-being are typically have positive externality, unlike, you know, unlike having people that are richer around you makes you less happy. Having happier people is typically positive for community well-being. But if you're very depressed, it's, you know, being around a lot of happy people doesn't do a whole lot for you. In fact, it may be negative. So it may be that the kind of the collective challenge of COVID had some, you know, modest mitigating effect for people who are in, actually clinically depressed. You know, again, I don't know, I'm overstepping a bit, but I think they're just unusual times and we don't fully know how all this is played out yet.
Certainly a lot of therapists talked about the fact that a lot of their anxious patients or patients who were sort of OCD felt like, now everyone knows what I feel like all the time, you know, when COVID came, because, you know, they felt like there was, you know, kind of this general, like a much greater understanding of what their day-to-day has looked like up until COVID. I think we have time for one more question. I'm going to prioritize one that I'm actually particularly interested in, which is sort of on the policy line. You said that people were more willing to entertain the notion of measuring well-being, and that in fact you think had we been tracking these measures of optimism or, you know, higher well-being, we would have had a better predictive been able to predict the trends a little bit better. So the question I have here is, are you gaining any traction with politicians, policymakers, civil society groups? And on policymaking, I'm wondering if the US, which now has a Foundations for Evidence-Based Policymaking Act, is going to help with these efforts.
Yeah, that was a question by Paul Allen, who I've worked with in the past on what works well-being in the UK, and it's a great question. And I think I alluded to this briefly, but I wrote this paper suggesting that we needed a coordinating task force or something that there are all these things going on, but nobody knows what anybody's doing. Everybody's in their silo, particularly for local level efforts. They're putting fires out every day, and they don't have just good access to information about what others have done and what works and what doesn't. So I wasn't proposing a new bureaucracy. I wasn't proposing something very expensive, but just that we did need some federal level logistical support, which included information sharing and potential small logistical support kinds of grants for local level agencies and for the national level agencies to coordinate. And then I just got this amazing response. People wrote me unsolicited from a lot of these agencies, from some of these other places. And we had a very small meeting at Brookings, like a working group to see where this might go. And we had Gus O'Donnell, who was the mastermind behind the UK's effort to get well-being statistics into their annual surveys, and also now as policy priorities, and representatives from EMS first responders, from HHS, all over the place, and some of the local level actors in the well-being space. And the momentum has been incredible. And even now we're seeing in the House, they've passed about 5 different bills about mental health prevention, efforts. They're all different. I'm not sure how well coordinated they are. But again, the point is that if we had a way to make sure all different parts of this puzzle were at least speaking to each other, we would have a really good start. And the other thing, we're hoping to produce a sort of a white paper of sorts that just calls for the need for consistency in measurement and for reliance on the best practices established by the OECD, established by our own National Sciences Panel on Wellbeing Metrics, which I confess to have been on. But I don't think it's a self-interested thing here. It's just, if everybody's measuring this differently, we're the only wealthy country in the world with no national level statistics that include some well-being questions. It's not expensive. It's not that difficult. There's just no coordination at the moment. So at the least, we're hoping to make some traction with that very simple recommendation. The coordination thing may take a bit more time, but it's one of the few times I've written something posted in sort of an internet, you know, just a Brookings series thing that I haven't gotten, at least not even one nasty comment. It's amazing. All positive so far. So maybe, you know, maybe we're onto something.
Well, I think so. Although interestingly, I have been talking with the CDC about tracking well-being, and they claim it's actually very expensive. So, you know, they wouldn't say that it's not expensive, but I see we are over time, and I'm sorry because we have so many additional questions, and I apologize to anyone whose questions didn't get asked. And I think we'll just have to invite Carol to come back and have some more discussion with us about these really important and fascinating topics. So thank you again, all of you, for coming, and we look forward to seeing everybody next year in September. We're going to pick up our series again with a focus on recovery and resilience, centered on lessons learned and well-being from the pandemic and how they can inform our understanding of resilience and well-being post-pandemic. So Carol, since you're clearly doing this work, maybe we'll just have you come back next.
I'd love to. It's a great group.
That would be great. Thank you all so much. And special thanks to you, Carol, for joining us, and we'll be in touch.
Yeah, thanks for hosting me.
The work by Michelle Lamont. We'll be happy to share that.
Yes, yes, please.
Okay, thanks so much.
All right. Bye. Thank you all.